Um, this is the brachial plexus, and I have to admit, I'm probably the only doctor in the country that will admit that they have never contoured the brachial plexus correctly, and probably never will. And if you think that you've contoured the brachial plexus correctly, it should come out looking like this. And if it doesn't look like this, you've done it wrong too. Um, if you had to contour the brachial plexus and make it like this, you'd give up. And I think one of the biggest barriers to contouring the brachial plexus is that if you get into it and study it, and you realize you have to draw something like this, it just sounds like an impossible task, and you give it up, and you settle for the spinal cord and the parotids and the hyoid bone because those are a whole lot easier. But it's not, horribly, that's not that impossible. And if you think that radiation therapists drink cold beer was all just made up, here's the 5 roots of the brachial plexus, the 3 trunks, the 6 divisions, the 3 cords, and all of the terminal branches. So you can have your beer this weekend and know that you're studying properly. If you pull out the Netter's anatomy book, this will also show you some of the anatomic relationships for the brachial plexus. And if there are just 3 things that you want to remember from the entire day, you want to remember the anterior scaling muscle and the middle scaling muscle and the subclavian artery. And the reason that that's important is when you're in the upper part of the brachial plexus, way above the clavicle, you'll notice that the entire brachial plexus travels between the anterior and the middle scaling muscles. So that's great. If you contour in between there, you'll know that you're getting the brachial plexus. If you're following the carotid artery all the way down the neck, you're in the wrong place. When you get down to the clavicle or so, just follow the subclavian artery and you'll be okay. You don't have to worry about what part of the brachial plexus sits below it and what part sits above it. Just contour the whole subclavian artery, give yourself a little margin, and you're not going to miss. And so the simplified method I'm going to give you is just to contour everything between the anterior and the middle scaling up above, and then just follow the subclavian artery on your way below, and you'll be wrong, but that's only because you're putting in more than you want, because you don't really have those little spaces in there. But we want to do something so that we don't drive ourselves crazy, but we still keep from hurting patients. If you look at it on an MRI scan, you'll notice that the sternocleidoid muscle sits there. There's your scaling muscle, and here's the root coming out of C8. You may say, what in the world is a C8? I thought there were only C7. Go back 2 slides. If you go back to the original anatomy, you'll notice that on the top part, the cranial nerves sit above the vertebral body, but then when you get below, then they go below it. So C7 is on top of C7. C8 is at the bottom part of C7, and then the T1 nerve root comes out at T1. So that's how you end up with C5, 6, 7, and 8, and T1 being in the brachial plexus, even though you don't have a C8 vertebral body. I went ahead and looked up some of the different references that give you very detailed methods for how to contour the brachial plexus. Again, I think the thing that the best ones have in common is the importance of the subclavian artery and the anterior middle scaling muscles. And again, you want to go from C5 down to T1, and the first rib sits at the T1 level. I'm not going to spend a lot of detail on these. I'm going to give you the reference. You have the references there so you can look those up, because I'm not going to have you do anything that's that difficult. I have a much more simple mind, and I don't like 9-step ways of doing anything. The Princess Margaret Hospital also gives its way of contouring the brachial plexus. And this is a little bit wrong too, because you remember that the brachial plexus runs from C5 through T1. It's only in a very rare person that T2 gives a contribution to the brachial plexus. and in a very rare person that T4 gives a contour to the brachial plexus. And I think if you're contouring someone, you ought to just sit with C5 to T1 and not try to look for those tiny little pieces of T2 that you'd never see without a very high detailed MRI scan, and most of us don't plan off of those anyway. There is a diagram that shows all the relationships that are published, and I give you the reference for all of these. I don't intend for you to actually get much out of that right now, except to just know that it's there and that it's all available if you want to do it. I'm going to give you a little bit examples where we have the images drawn up a little bigger. The thing to really pay attention to is this anterior scalene muscle, and there's your posterior scalene muscle and your brachial plexus, this thing called BP. This author has you just contour the middle part of that. I actually will have you contour more of that because the brachial plexus is going to move in and out all throughout that territory, and to get exactly the position between the anterior and the middle scalene muscle, I think is a bit hard, so I would just have you contour this whole section between the anterior and middle scalene muscle unless you really feel compelled to try to get something that looks like the Netter diagram, which I don't think is clinically useful. One of the things I want you to think about is that when we treated patients with just lateral fields in the head and neck area, all of our hot spots tended to be anterior, and so the brachial plexus was safe. And we rarely had hot spots down posterior because that was an area that was kind of being at the edge of the field as we split to go to our electrons after 44 gray or so. And so the brachial plexus with conventional treatment was almost never in a hot spot. But now that we're doing IMRT and we're sparing the cord, we can pop pretty powerful hot spots between those anterior middle scalene muscles. In fact, we probably do so quite often. And so the reason for contouring that whole space to protect the brachial plexus is just to make sure that you don't end up with something greater than 110 hot spot inside the brachial plexus, and you're not doing that for 30 or 35 fractions, which would not do your patients any favors. Again, especially as we're using our IMRT to keep our spinal cord low, and also there's a lot of people who are working hard to keep their larynx doses low in order to protect the pharyngeal constrictors. We have even greater tendency now to put hot spots right in the middle of the brachial plexus than we ever did before, and I contend that that's not a good idea. And again, one of the other, to follow these out, you can watch the brachial plexus as it emerges from the C5 vertebral body. And again, this author gives you more detail than I do. I would go ahead and just contour this whole space between the two scalene muscles. And that way, since our goal is protection, we just want to avoid having big hot spots there. It doesn't hurt us if we're a little more generous, just like if we're a little bit generous in how we contour the spinal cord. That probably is better than if we don't. Again, this is another one of the contours that's available in the reference. And T2, again, really, it's only very rarely that T2 will give a contribution to the brachial plexus. But if you wanted to put in T2 just to have extra safety, I'm never going to fault you for that. One of the issues that's at stake, and one of the ways we can get brachial plexopathy, is if we have a very petite person or someone that's very thin, particularly if we're doing a head and neck field where we specify our supraclavicular dose as being at 3 centimeters depth. The brachial plexus might actually be only 2 centimeters deep in a pretty thin person, and